Assalamu alaikum. Our lecture today is about benign prostatic hyperplasia. At the beginning, we have to review or have to recall some points from the anatomy and physiology and pathology from the previous courses from the previous years. The male reproductive system consists of internal external organs, which are the penis, scrotum containing the testis, epididymis, and deferens, plus internal organ, which includes the prostate and the seminal vesicles. They are located in the deep pelvis behind the urinary bladder and in front of the rectum. Of course, the internal and the external organ are connected with each other with the vas deferens. This is a back view of the urinary bladder, showing the seminal vesicles on the back of the bladder, and the prostate at the base of the bladder. And here is the vas deferens connecting the epididymis and testis to the seminal vesicles. The point of union between the seminal vesicles and the vas deferens constitutes the ejaculatory duct. The prostate gland is part of the male reproductive system. It is present below the urinary bladder, in front of the rectum, right here. As you can see in the picture, this is the urinary bladder. The prostate is located just below the urinary bladder. It has a base which is directed above, below the urinary bladder, and apex which is directed below. The normal size of the prostate is about 2 by 3 by 3 centimeter, which is almost equivalent to the size of a walnut. The normal weight of the prostate is around. The prostate is traversed by two important structures: the prostatic urethra, right here, from the bladder, which contains then pulmonary urethra, then anterior urethra, and the ejaculatory duct. As we have said in the previous slide, the ejaculatory duct is formed by the union of the vas deferens with the seminal vesicles at the back of the urinary bladder. When they both unite, they form the ejaculatory duct, which opens into the prostatic urethra at the verumontanum. This part where the ejaculatory duct opens is called the verumontanum. These two important structures travel through the prostate. According to embryologic and biologic basis, the prostate has several zones, which are called central zone, transition zone, and the peripheral zone. This is a cut section transverse, and this is a cut section longitudinal. Here is anterior, and here is posterior. Here is superior, here is anterior. Here is anterior, in this section here is anterior, and here is posterior. The central zone is a wedge-shaped area, which is around the ejaculatory duct and posterior to the urethra, behind the urethra, the upper part, behind the upper part of the urethra, around the ejaculatory duct. You can see it here, right here. It's behind the upper part of the prostatic urethra and around the ejaculatory duct. You have the transition zone. It's around the upper part of the prostatic urethra, but it's in front of the urethra. So the upper part of the urethra you have in front is called transition zone, and behind is called the central zone. Peripheral zone, which is the biggest part, it looks like a cup which envelopes or includes both peripheral and the transitional zone at the upper part of the prostatic urethra, and it's related directly to the lower part of the prostatic urethra. The central zone constitutes about 25% of the prostate gland volume, while the peripheral zone, which is the largest, constitutes about 70% of the volume of the prostate gland. From the peripheral zone, most of the prostate cancers arise. Around 70 to 80% of prostate cancer arise at the peripheral zone. Transition zone occupies only 5%. This is the anatomy in a normal adult. However, with age, this part, with only 5% part, starts to grow and hypertrophies, and this is what forms BBH. So we have BBH starts at the transition zone, which starts to grow at the expense of the central zone, and we have cancer, which arises in the peripheral zone. This zonal anatomy is very important, as each zone has a different biology. The function of the prostate, it contributes in the production of the seminal fluids. 1/3 of the seminal fluid is produced by the prostate, which contains nutrients, fructose for the sperms, zinc and citric acid. plus PSA, which is prostate specific antigen, which is responsible for making the semen fluid and thin consistency. So from the previous slides, although the prostate belongs to the male genital system, but it has a very intimate anatomical and functional relationship to the lower urinary tract, as it lies immediately beneath the urinary bladder and it surrounds the urethra. Therefore, any prostatic disorder or the treatment of such a disorder may be manifested by both urinary and sexual problems, especially in elder men. So what's the pathology in BPH? BPH is the most frequent disease in aging men. It's benign, non-cancerous enlargement of the prostate gland. This enlargement is due to hyperplasia or due to increased proliferation of the epithelial and stromal tissue. And as we have mentioned before in the previous slide, such growth starts at the transitional zone area, then it includes the rest of the gland, or it compresses the remaining part of the gland. BPH is a benign condition, it's not precancerous. However, BPH and prostate cancer may coexist in the same time, but BPH by itself is not precancerous and it has no relation to malignancy, but the patient may have both pathologies at the same time. BPH causes infravesical obstruction by two mechanisms, mechanical component and a dynamic component. Mechanical components due to the bulk of the growth, or caused by the bulk of the hyperplastic tissue. It causes compression of the urethra. However, the size of the prostate does not correlate with the severity of the symptoms. The second component, BPH may cause urinary obstruction or infravesical obstruction, is what's known as the dynamic component. Recent studies has shown that the prostate tissue and the bladder neck contains abundant adrenergic receptors. With increased adrenergic tone, this causes contraction of the smooth muscle at the bladder neck and at the prostatic capsule and in the smooth muscle in the stroma of the prostate. This causes increased resistance to urine flow. So, enlarged prostate or BPH may cause urinary obstruction through two mechanisms, either mechanical by the bulk of the hyperplastic tissue itself, or due to contraction of the smooth muscle at the bladder neck or at the prostatic capsule or in the rest of the prostate. So, what's the effects of obstruction? It has two phases, or the body responds to obstruction by two phases, compensation phase and decompensation phase. Compensation phase, the detrusor muscle, which is the muscle of the urinary bladder, starts to hypertrophy and attempts to overcome such obstruction. So in order to try to empty urine, this will lead to thick bladder wall, trabeculation. Trabeculation means hypertrophy of the muscle bundle of the bladder wall. This leads to diverticulum and cellulite. Diverticulum means herniation of the mucosa through the bladder wall. I'll show you a picture of a diverticulum later on. This will cause an increased intravesical pressure. However, the detrusor cannot maintain its hypertrophy for a long time. For this reason, the patient enters into decompensation phase. If obstruction becomes complete or the condition becomes untreated, unfortunately, the detrusor becomes fatigued and weakness starts. Whenever the detrusor, which is the bladder wall, starts to become weak, there will be inability to empty the urinary bladder urine properly. This will lead to increased residual urine volume or even urine retention. If the urine retention occurs, this urine retention may be reflected up to the ureters and kidneys and causing kidney dysfunction. Two important factors are required for development of BPH. First, androgen. There has to be androgen. And second thing is aging. Testosterone, which is the main male androgen, is converted to dihydrotestosterone in the prostate. Dihydrotestosterone is the main growth factor or main growth hormone for the prostatic tissue. Therefore, castration or any drugs or any medical condition that interfere with androgen production may improve BPH or shrinks BPH and improves symptoms. So dihydrotestosterone is a key factor in the formation of BPH. So you have to know this information because some drugs are directed for treatment for BPH are directed toward dihydrotestosterone. Second thing is aging. BPH occurs only in aging men. It does not occur in young adults. This is due to progressive accumulated effect of androgen on prostate growth. The prevalence of BPH 20% of men at their 40s, 50% of men at the age of 50, and 80% of men above age of 80 years. So what are the complications of VBH, obstruction of VBH? As we have seen in the slide of pathophysiology, will start to cause increased residual urine. The bladder will not be able to empty properly. This residual urine may even progress to retention, which could be acute or chronic. The difference between acute and chronic: acute retention occurs rapidly and is painful. Chronic retention occurs very insidiously or very slowly, and the patient is unaware of it because it is painless. It's only discovered during physical examination. This residual urine or this retention may predispose to urinary tract infection, inflammation. The high intravesical pressure may be reflected to the upper urinary tract, kidneys, and ureter, and may cause renal failure, especially in patients with chronic retention. As we have seen in the slide of the pathophysiology, may cause bladder diverticulum. This is a picture of diverticulum due to herniation of the mucosa through areas of weak muscle. The problem with diverticulum is when it is filled with urine, it can't empty itself because it has no smooth muscle in the wall of the diverticulum. So urine remained in the diverticulum will be a source of infection and a focus for stone formation. Also, BBH is a common cause of hematuria of men above age of 40 years. Also, straining due to obstruction, urinary obstruction, may predispose to hernia formation or hemorrhoids or changing the bowel. Diagnosis. So, a patient with BBH, what would be the symptoms he's presenting with? We have group of symptoms which are called lower urinary tract symptoms. First group of symptoms are irritative symptoms which occur during bladder filling. These symptoms could be urinary frequency. The patient with BBH, he would go to the bathroom more frequent than a normal person. Normal person would go to the bathroom maybe 3 or 5 times per day, but a patient with BBH maybe has to visit the bathroom every an hour, or total 7 or 8, maybe 10 times per day. So first thing, BBH causes urinary frequency, increase the urinary frequency. Second thing, causes nocturia. Nocturia means nighttime frequency. A normal subject maybe doesn't get up at night, maybe only one time at most, to visit the bathroom. But a patient with BBH may get up from sleep in order to go to the bathroom to void or to urinate several times, maybe 3 times, 4 times, 5 times, according to the severity of the condition. Patient with BBH may also complain of urgency, which means the sudden desire to void, which is difficult to defer. A normal subject, when he experiences a first sensation to void, he can withhold it. He can withhold it till time is suitable or till the place is suitable. BBH patient, on the other hand, cannot withhold urine. Once he gets the desire to void, he immediately has to go to the bathroom immediately. He can't delay it. This is what's called urgency. May also cause incontinence, which is involuntary loss of urine. Second symptoms are called obstructive symptoms, which occur during voiding. A BBH patient during voiding, when he go to the bathroom during the process of urination, he may complain of or may he present with hesitancy, which means delay on the initiation of act of micturition. The patient has to wait for urine to start maybe several minutes in order to start, or he has to strain or void during urination. Also, he may notice that the stream is weak or interrupted, not as strong as it used to be. Also, he may complain of dribbling at the end of urination, or at the end he may have sense of incomplete bladder emptying because of residual urine. Also may complain of pain or burning during urination. This tool is called IPSS score, International Prostate Symptom Score. This tool is very important because it classifies the patient or measures the severity of the patient. There are 7 important questions from the complaints the patient is presenting with. Then we grade each complaint according to the frequency it happened. The important questions you have to directly ask the patient about sense of complete emptying, frequency, intermittency, urgency, weak stream, straining, and nocturia. Each one of these the patient grades, whether it's present all the time or most of the time or just a few times. Then at the end you will have a score. The least number you could have is 0, and the highest number after asking the 7 questions, if the patient gave 5 in all 7 questions, the highest grade you could get is 35. So according to the severity of, this is objective tool to measure the severity of symptom. You could have mild case or mild symptoms. If the score is 0 to 7, the condition is considered mild. If the score is 8 to 19, while it is considered severe if it is above 19, from 20 to 35. 35 is the maximum number. The 0, of course, is the least number you can get. Also, you have to ask about the quality of life, because the people are different. Some people are bothered with these symptoms. Some people could not be bothered. For example, a teacher or a doctor or somebody who works in an office, he could be bothered by the complaint of frequency or urgency. However, a man who is retired, who is staying at home, he could not be bothered by such symptoms. So it's very important to ask how the patient, how these symptoms are affecting his lifestyle, or how these symptoms are affecting his quality of life. After taking history, we do examination. You have to do careful abdominal examination and to check whether there is urine retention or not, or presence of signs of urinary tract infection. You have also to do a thorough neurological examination, because a lot of neurological conditions may simulate PBH. Neurological examination in the form of perineal sensation, examination of the anal sphincter tone, and the bulbocavernosus flex. Digital rectal examination is very essential part, because digital rectal examination, this is how you directly feel the prostate and see whether it is enlarged or not. This is a picture from the back. This is the examining finger. You have to carefully examine both lobes of the prostate. What do you look for? You look for the size. We already know the normal size of the prostate is 2 by 3 by 3, which is almost the size of a walnut. If it is enlarged above this size, so it is enlarged. You have to feel both lobes separately. You check for the consistency of the prostate, which is normal consistency is rubbery. In malignancy, it would be stony hard. In case of infection, prostatitis or infection, it will be tender. You have to check for the median sulcus, which separates both lobes, and the lateral sulci at the lateral border of the prostate. In case of prostate cancer, the median sulcus will be obliterated. In BPH, as the prostate grows, the lateral sulci will become more deeper. This is one of the methods you assess the size of the prostate. Also, you have to check the symmetry of both lobes. Both lobes should be equal, or should be very similar to each other. Also, you have to check for the absence of any abnormalities, any irregularities, or any hard residuals suggest prostate cancer, and this patient will be subject or will be required to do a prostate biopsy. Also, you have to check the tone of the anal sphincter, whether it is increased or weak or normal, because a lot of neurological conditions will affect the tone and may produce symptoms similar to BPH. Differential diagnosis, a lot of conditions may produce similar symptoms or similar signs to BPH. Most important is the urethral stricture, which could be caused by trauma or instrumentation or inflammation, bladder neck contraction, metal stenosis. All these conditions will produce also infravesical obstruction like BPH, but mostly they will happen in a younger patient than the BPH patient. In addition, there will be history of trauma, history of instrumentation, or history of inflammation or sexually transmitted disease. Also, you have to check there is no carcinoma in the bladder or the prostate. Both conditions could produce similar symptoms to BPH, frequency or hematuria or dysuria during urination. Also, you have to check for the presence of infection, cystitis and prostatitis. Although they could be a complication of BPH, they also could produce a similar clinical picture to BPH. Bladder calculi could also occur as a complication of BPH, or if it is primary, it could produce a clinical picture similar to BPH. And the neurological abnormalities, such as the cerebrovascular accident, multiple sclerosis, or diabetes mellitus, could also produce very similar symptoms to BPH. All these conditions you have to check for, and you can differentiate by taking a proper history and doing a proper examination and the investigations. So what would be the investigations required of BPH patient? Of course, the first thing we start with is a urine analysis and urine culture to make sure there is no urinary tract infection. Do urine cytology if you suspect bladder cancer. Do kidney function, serum creatinine. This is essential, as we have mentioned before. kidney dysfunction could be a complication of BPH, so you have to check kidney function. And do PSA, which is prostate-specific antigen. This is important for screening for prostate cancer. There is a great overlap of BPH and prostate cancer. We have said before, BPH is not precancerous. These are two separate clinical entities. The normal PSA should be less than 4 nanogram. Less than 4 nanogram. If it is above 10 nanogram, this is definitely prostate cancer, and this patient requires prostate biopsy. So there is no problem in patients with PSA less than 4 nanogram or PSA less than 4 nanogram. The clinical dilemma, if we are having PSA between 4 and 10, this is called the gray zone. PSA is organ specific but not disease specific. This means organ specific, it arises from the prostate. It means there is a prostate pathology, or there is a disease in the prostate gland. But in the gray zone, it does not specific. It doesn't say what is this disease. This disease which raises the PSA could be prostate cancer, could be BPH, could be prostatitis, or could be any prostatic manipulation, including biopsy or digital rectal examination or cystoscopy. So if the PSA is less than 4, that's no problem. This is normal. If PSA is above 10 nanogram, this is definitely prostate cancer, and this patient warrants biopsy. But the dilemma is when the PSA is between 4 and 10. It could be malignancy, and it could be benign condition. Benign conditions such as BPH or prostatitis or prostatic manipulation. So should I do biopsy for all these patients? This would be too much. So there are several factors that could improve the performance of the PSA in this gray zone, because it would be too much if I do biopsy for every patient with PSA between 4 and 10. So what are these maneuvers, or what are these tools? The first thing, we have age adjusted. For each decade, there is a special range for PSA. It would be considered normal if it is within the gray zone. Second thing is we do what called PSA density. We divide the value of PSA above the volume of the prostate as measured by ultrasound. If the value is above 0.15 nanogram per milli per cc, this is would be leaning toward malignant side. So I do biopsy. If it is less than that, it's most probably a benign condition. Or I could use a free PSA ratio to total PSA ratio. If this ratio is below 25 milligram, this leans toward malignancy. So this patient would require a biopsy. PSA velocity, this requires three measurement of PSA on 3 different occasions over a period of over 10 years. Then I see through this velocity how fast is the PSA is progressing. If it is progressing too fast, this would be more likely to be malignancy, and this patient would require biopsy. These are tools which help me which patient in the gray zone. These parameters only applied on the patient in the gray zone, which I couldn't tell it is benign or malignant condition. So these tools would help me to do if it's more likely to be benign or malignant. Imaging, I have to do also imaging. Most commonly, I do abdominal ultrasound. Abdominal ultrasound would help me in assessing prostate volume, although it's not very accurate. Also, it visualizes the bladder. It could tell me if there is any bladder stones, a bladder diverticulum. It also could measure the post-void residual urine if it is increased. Also, it assesses the kidney if there is dilatation. I could see a stone here in the bladder. I could measure the urine volume in the bladder before and after urination. If there is a high increased post-void residual, it will be evident on ultrasound. Another tool, but it's optional because it's more painful or more complicated than abdominal ultrasound, which is transrectal ultrasound. It measures the prostate volume very accurate, and it has a very important role in screening and detecting prostate cancer. Prostate cancer appears as a hypofocal lesions in the transrectal ultrasound. Also, it's very helpful in obtaining guided biopsy from these lesions. The basic thing in imaging in BPH patient is abdominal ultrasound. However, if the patient is presenting with hematuria, I have to do computed tomography because there might be another source or another cause of bleeding other than BPH. So I have to make sure the cause is not cancer. So I do CT or computed tomography only if the patient is presenting with hematuria. Otherwise, abdominal ultrasound will be very sufficient. Another optional investigation is urodynamic studies. Urodynamic studies could be as simple as uroflowmetry. There is a long list of urodynamic studies. There are some more complicated tests like cystometry or pressure flow study. This is an optional investigation. Uroflow is the simplest of all these. The patient voids in a special receptacle, and this device measures the flow of the urine. I could use this as a baseline before the treatment, and I could use it for follow-up to see the progress of the condition of the patient. More sophisticated urodynamic evaluation would be required when I suspect a neurologic disease, because, as we said before, neurologic disease could produce a clinical picture very similar to BPH. How would I differentiate? Urodynamic is the one of the methods which could help me to differentiate between such symptoms which are caused by neurologic deficit or by BPH. Of course, besides the neurological examination, diabetes mellitus also is an indication to do urodynamic testing. Also, prior to invasive treatment, if I decide to do a prostatectomy, it would be wise to do a urodynamic test to make sure of the diagnosis. Also, I have to do urodynamic test in a patient coming with atypical presentation. For example, two young patients coming with BPH signs and symptoms. This is a typical case. So I would require a urodynamic study. Maybe there would be an alternative treatment. We have many lines of treatment, including watchful waiting, medical treatment, or surgical intervention. Watchful waiting, we are just not simply sending the patient home. No, we are put him under regular follow-up to see the progress or regress of the case. Plus, we give him instructions on behavioral modifications besides the follow-up. Medical treatment, here we give patients certain drugs. We have alpha-adrenergic blockers, 5-alpha reductase inhibitors, and phytotherapy. Alpha-adrenergic blockers and 5-alpha reductase inhibitors, these are the major or the most effective treatments, medical treatments for BPH. Phytotherapy has a modest role, and we will discuss all of these in details later on. Surgical intervention, if surgery is required to remove the prostate, I have also several options. TURP, which is transurethral resection prostate, or laser, or do open prostatectomy with traditional surgery. TURP or laser, this is endoscopy. This is endoscopy, not open surgery. Open prostatectomy is open surgery. We have also a third option, which is minimally invasive procedure. Choose line of treatment, whether watchful waiting, medical treatment, surgical intervention, according to severity and bothersome of symptoms. Patient, of course, coming with mild symptoms, I wouldn't do surgery. I would start with watchful waiting or medical treatment. Also, presence or absence of complications. Of course, a patient presenting with complication would require a more aggressive treatment or more active treatment, such as surgical intervention. I can't give a medical treatment in a patient coming with complication like hematuria or renal failure. So, presence of complication would help me to choose which line of this, or according to the severity of symptoms. Watchful waiting, which means regular follow-up plus behavioral modification, this is suitable for patients with mild symptom score. We said before, we do scaling of the symptoms, whether it's mild or moderate or severe, according to the IPS score. So if the score is less than 7, this is considered a mild case. 1/3 of the patient may improve by their own without any medication. The instructions I give to the patient to reduce his symptoms, especially frequency or nocturia, is I don't do fluid restriction, but I advise the patient to avoid drinking large amount of fluids over a short period of time. Also to decrease the intake of diuretic fluids such as alcohol or caffeine. Also to decrease the nighttime fluid intake. Also should avoid bladder irritants which make him go to the bathroom more frequently, especially carbonated beverages. Also, I should encourage frequent voiding and avoid withholding urine. Medical treatment, I give drugs, medications to the patient. This would be suitable for patients with moderate score, less than 19. Absence of BPH complications. I can't give a medical treatment for a patient with a complication. The advantage of medical treatment or medication is simple and convenient. Most drugs are used as a single daily dose, generally safe, few side effects, usually tolerable or can be dealt with. But disadvantage of medical treatment is only symptomatic. It does not cure BPH. So as long as it only relieves symptoms. So as long as the patient takes the drugs, it improves the symptoms, but it does not cure BPH. This is an important point about the medical treatment. Also, therefore, for this reason, treatment is required for several months or maybe years. This would create a financial burden for the patient because most of the drugs are very expensive, and this also requires a compliant patient. Another point for this advantage is the interaction with other medications. So what drugs do we have? First class is the alpha adrenergic blockers, which are the most important or the most effective or most important drugs in the treatment of BPH. Mechanism of action, as you remember, we have said there are two mechanisms of prostatic obstruction. The one is the dynamic component. Alpha adrenergic blockers work on the dynamic component of obstruction. Adrenergic receptors present in the prostate and the bladder neck. If there is high adrenergic tone, it starts to contract. Alpha adrenergic blockers abolishes this contraction. So it facilitates urine flow through relaxation of the smooth muscle in the prostate capsule and in the bladder neck. There are several receptors, several adrenergic receptors, which could be present in the prostate and the bladder neck and in the blood vessels as well. According to selectivity for these receptors, whether it's present on the blood vessel or the prostate, alpha adrenergic blockers are classified into non-selective, which acts on both receptors which are present in the prostate and in the blood vessels, such as doxycycline, trazodone. The problem with these drugs, because it acts on the alpha adrenergic receptors present in the blood vessels, it could cause vasodilatation and hypotension. This is very important. Selective drugs act directly on the alpha receptors present on the prostate tissue only, so they do not cause hypotension or changes in the blood pressure. We have selective like alpha-cytosine and super selective like tamsulosin. So, according to selectivity to adrenergic receptors, alpha blocker classified into non-selective, which works on both adrenergic receptors in the prostate tissue and in the blood vessel, so they could cause vasodilatation and hypotension as a side effect. And there are better drugs or more developed drugs such as selective or super selective, which include alpha-cytosine and tamsulosin. These drugs act only on adrenergic receptor present in the prostate or bladder neck only. They do not act on the adrenergic receptors present in the blood vessels. Thus, they do not cause hypotension. These are the dosages. Selective drugs, only single dose, like alpha-cytosine, 10 milligram, tamsulosin, 0.0 milligram, or if I need a higher dose, I would use 0.0 milligram, single dose. Non-selective like trazodone and doxycycline, because they cause hypotension, so they must be given titrated in small, gradually increasing dose till reaching therapeutic dose required. I can't give in full therapeutic dose at once. This would cause sudden hypotension to the patient. Therefore, they have several concentrations. Trazodone or doxycycline starting from 1 milligram till maybe 20 or 16 milligram. You have to know these concentrations. So, non-selective, because they act on adrenergic receptors both in the prostatic tissue and in the blood vessels, so they may cause hypotension. Therefore, when I give these drugs, I have to give them in titration, which means slow, gradually increasing dose. They stay on 1 milligram for few nights, then 2 milligrams for few nights, then 5 milligrams. I increase the dose according to the response, but I have to introduce the drug in small, gradually increasing dose. This problem does not occur with the selective drugs. I could give full therapeutic dose with the selective with no problem on the blood pressure. All alpha blocker, whether selective or non-selective, they all have equal clinical effectiveness. The difference is only in the side effect profile. Non-selective as they act on the adrenergic receptors in the blood vessel and the prostate, they could cause vasodilatation, hypotension, easy fatigability. On the other hand, selective or super selective, which act on the adrenergic receptors on the prostate, on the bladder neck only, they do not cause hypotension, but they cause sexual problem in the form of retrograde ejaculation or may cause nasal congestion. As we said in the previous slide, doxazosine and trazosine, which are non-selective, those must be titrated before reaching therapeutic dose. The other class of drugs for treatment of VVH are the 5-alpha reductase inhibitors, as mentioned before. Dihydrotestosterone is the most important androgen for stimulating prostate growth. So these drugs act as a reductase inhibitor, which is responsible for conversion of testosterone to dihydrotestosterone. So these drugs prevent dihydrotestosterone or prevent the which is the major growth stimulant in the prostate. So they may decrease the prostate size by about 25 to 30%, but this is not always occur in all patients. Also, this therapeutic benefit is achieved only after several months of treatment, maybe 3 or 6 months after treatment. They are less effective of relieving BPH symptoms than alpha blockers. So alpha blockers are more effective. Side effects are related to its anti-androgen effect. They may decrease libido and may cause erectile dysfunction and decrease ejaculation volume. They also may cause breast enlargement and tenderness. We have 2 drugs in this category. Finasteride, it blocks about 70% of dihydrotestosterone. Dose is 5 milligrams once daily. We have a more potent drug, dutasteride. It blocks 90% of dihydrotestosterone because it acts on the two isoenzymes form of the reductase enzyme. Daily dose is 0.5 milligram once a day. Each drug is administered only as once a day. I could use combination alpha blocker with 5-alpha reductase inhibitor. There is no problem. This would be suitable for patients with prostate size more than 40 grams, but this will be a significant financial burden because both drugs are very expensive, and as we said, the patient would be requiring medication for a very long time. It could be months or years. Another form of drugs for treatment of VIH is called phytotherapy, which is herbal therapies from natural plants extracts like sopalmetto and pumpkin seed, but these are very mild preparations. They do not produce a significant therapeutic effect. Main mechanism, they act through anti-inflammatory or anti-edematous action, so they may improve urinary symptoms just a little bit. Other medications that may be used during the treatment of VVH is anticholinergic, especially for patients with frequency, nocturia, urge incontinence. All the anticholinergic would be helpful in reducing symptoms of overactive bladder. Also, if there is urinary tract infection, antibiotic or urinary antiseptics will be required. Surgical treatment, it would be required to remove the prostate. If failed the medical treatment, if the drugs patient tried and didn't produce much improvement in the symptom, then I would think of surgery. Also, I could offer surgery as a first line of treatment in patient with severe score above 19. Also, if in the presence of complication. Complication could be refractory urine retention, recurrent urinary tract infection, recurrent hematuria, or urinary calculi, or diverticulum, or of course renal insufficiency. All these complications, of course, will be an indication to surgery. I can't give medical treatment or watchful waiting in a patient coming with a complication. So, what are the options? What are for surgical intervention? I could have endoscopic options like TURP, transurethral resection, prostate, or laser, whether resection or vaporization. We will know the difference between resection and vaporization in a second. Or open prostatectomy. These are endoscopic procedure. Open prostatectomy, this is open surgery. Or minimally invasive modalities. How would I choose between these options if surgery is required? Choice is according to general condition and fitness of the patient to surgery. These two are major intervention, so they require a surgically fit patient, a healthy patient. This this last one could be used for patients who are poor medical risk or who can tolerate major surgery. Also, the size of the prostate is important determining factor, or the presence of associated pathology. Some problems, some associated pathology could be solved with endoscopy, others could not be solved by endoscopy and require open surgery. Also, the availability of equipment like laser, it's not always available in all medical centers. TUR, of course, and open surgery are available in all centers, regardless regions. For open surgery, the goals are to restore urinary function and at the same time try to maintain sexual function, because all treatments of prostate cancer, prostate disorders may influence sexual function. Also, we have to assure patient safety and fitness to operation. Preparation, because this is a major intervention, we have to control bleeding tendency, stop non-steroidal anti-inflammatory, anticoagulants, because most of the patients are elderly patients. They could be taking these medications for cardiac problems or for cerebral stroke or other neurological problem. Active urinary tract infection must be treated. Also proper assessment of hepatic function and the cardiovascular and pulmonary function, because these are major operations. First, we will talk about endoscopic procedures. We have transurethral resection, what we call TURP, transurethral incision. Instead of resection of the whole prostate, I could do just incision to open the way. This is according to the size of the prostate. Or I could do laser. Laser is very similar to standard transurethral resection. The difference is only in the energy source. Here I use laser machine as a source of heat for treating the prostatic tissue. In transurethral resection, I use heat generated from electrosurgical unit, which is diathermy. So they are basically the same procedures, but different energy sources. So transurethral resection, the procedure is performed under general or spinal anesthesia, performed through a rigid endoscope, is introduced through the urethra, of course under anesthesia. This is a diagram of the receptoscope reaching the prostate. In case of standard transurethral resection, I use an electrode or loop, which is connected to electrosurgical unit, diathermy. Or in case of laser, I use a laser fiber, which is connected to laser generator. In either forms, I use heat to destroy the obstructing prostatic tissue. This is an endoscopic view. Here is two lateral lobes completely obstructing the urethra. We call this sign kissing of lateral lobes, because they are touching each other or meeting each other and then also obstructing the urethra. I deal with this obstructing prostatic tissue with thermal energy. So according to the heat, I could use what called coagulation. If the heat of the electrode or the heat of the laser fiber is less than 60 degrees, this causes coagulation. This causes thermal necrosis of the obstructing tissue, and the necrosis tissue will slough off later on. Or I could use heat higher than 60, between 60 and 100. This will cause resection, will cut the tissue into small pieces. Or I could use temperature higher than 100, and this is called vaporization. So the difference between coagulation or resection or vaporization, you may hear a lot of terms. This will depend on the temperature used during the thermal treatment. So coagulation is temperature less than 60, it will cause thermal necrosis of the tissue, and the necrosis tissue will slough later on. 60 to 100 degrees, this will cut the tissue into pieces. Above 100, this is called vaporization. Vaporization will cause immediate tissue ablation. The tissue will disappear because it's converted into vapor or steam. This is why it's called vaporization. Post-operative care, I have to monitor vital signs because a lot of bleeding could occur during the procedure, so I have to monitor the vital signs. Medications in the form of antibiotics, analgesic, DVT prophylaxis. Hematuria and the blood clots are expected to occur within the first 24 to 36 hours. Therefore, I have to do continuous irrigation through a triple way polycaster to maintain catheter patency and avoid clot retention. Catheter is removed after the procedure within 3 to 5 days. For recovery, patient can return to his normal life within 4 to 6 weeks. or in the loop or fiber I use. Sorry about that. Results of laser are generally comparable to TUR, which is the gold standard treatment. Advantage of laser is less post-operative pain and shorter hospital stay. Also, laser is better than standard TUR in controlling hemorrhage or in hemostasis. Therefore, less hemorrhage occurs with laser. It can be used, even used in anticoagulated patients, and has less TUR and less overall complication rate. But the overall results are comparable or more or less to standard TUR. Disadvantage of laser: it's very expensive equipment and accessories, and the limited availability is not available as TUR in all medical centers or all medical care hospitals. Second option after endoscopy is open prostatectomy, open surgery, open traditional surgery. When should I restore to open surgery? If the prostate is larger than 90 grams. This would be too huge to deal with laser or with standard TUR, so I do surgery. Surgery would be more feasible. It would take less time and less complication. Also, if I have another problem that could not be solved with endoscopy, or it would not be safe or feasible to solve with endoscopy, so I have prostate plus huge bladder stool. Bladder stool less than 2 centimeters I can deal with endoscopy, but if it is larger than 2 centimeters, it's better or safer to do with open surgery. Also, if I have bladder diverticulum, endoscopy can't correct or can't deal with bladder diverticulum. If there is a large bladder diverticulum, I have to do also open surgery. Open surgery approaches to the surgical approach to the prostate. We have abdominal approach through abdominal incision. First one is retropubic, direct access after I make an abdominal incision, a direct access to the prostate through the prostate capsule, or the most commonly used is transvesical. I open abdominal incision, then I open the bladder and I access the prostate through the bladder. That's why it's called transvesical. There is a third route which is less commonly used, is perineal. I have to do perineal incision and access the prostate. This is very, very much less used. Most commonly used, the procedure is transvesical. Minimally invasive procedures, these are preserved for poor risk patients. Standard TUR is major intervention and requires a surgically fit patient, good general condition, good cardiovascular condition, good pulmonary condition. However, PBH occurs in geriatric group, all the patients. A lot of patients could have cardiac problems, pulmonary problems, hepatic problems. These patients would not tolerate major operation, and they could require, they could have suffer from failed medical treatment, and they would require an additional procedure to solve their problem. So what would be the solution? We have what we call minimally invasive procedure, which could be done under local anesthesia as an outpatient procedure. Options include transurethral microwave therapy or transurethral needle ablation. Both these procedures also uses heat like TUR, but they are less effective. Also, I could use urethral stent. Results of these techniques are very modest, and they only provide temporary short-term relief. However, these patients are not good candidates for general surgery, and this is the best I can offer them. Thank you. If you have any questions, I would like to hear through the administration, and good luck, inshallah. Thank you.